discuss the etiology, clinical features, investigations, and management of hemophilia A or anti-hemophilic factor, that is factor 8. Hemophilia A, classic hemophilia, is a hereditary bleeding disorder due to deficiency of coagulation factor 8. Most of the cases are due to the quantitative reduction of factor 8. However, a small number of cases are due to the qualitative defect in factor 8. Hemophilia is an X-linked recessive disease and hence males are usually affected. However, rarely female carriers can be affected if their normal X chromosome is also disproportionately inactivated. Females may also become affected if their father is hemophilic and mother is a carrier. Antenatal diagnosis can be made by chorionic villus sampling or amniocentesis. Pathogenesis. Factor 8, that is anti-hemophilic factor, is a large, that is 265 kilodalton single chain protein that regulates the activation of factor 10 by proteases generated in the intrinsic pathway. Hence, deficiency of factor 8 leads to the defective coagulation and bleeding. Factor 8 is synthesized in liver and circulates in the blood. One Willebrand factor acts as a carrier of factor 8 in blood. The gene for factor 8 is on the X chromosome, and carrier detection and prenatal diagnosis are well established. 1 in 10,000 males is born with deficiency or a dysfunction of the factor 8 molecule. Hemophilia is classified as mild, moderate, and severe based on the factor 8 level in the blood. In mild hemophilia, factor level 5 to 25% of normal will be there. Excessive bleeding may occur after surgery or a dental extraction. Moderate hemophilia, factor level 1 to 5% of normal will be there, usually causes bleeding after minimal trauma. Severe hemophilia, factor 8 level less than 1% of normal will be there, causes a severe bleeding throughout the life, usually beginning soon after birth. Example, scalp hematoma after delivery or excessive bleeding after circumcision. Clinical features. Hemophilia A is the second most common congenital bleeding disorder after von Willebrand's disease. It is a severe bleeding disorder. Family history of hemophilia is usually positive. The bleeding tendency is related to the factor 8 levels. Patients with mild hemophilia bleed only after major trauma or a surgery. Those with moderately severe hemophilia bleed with mild trauma or surgery, and those with a severe disease bleed spontaneously. Bleeding can occur anywhere, but commonly occurs in deep tissues such as joints, that are knees, ankles, and elbows, muscles, and from GIT also. Bleeding into joints, that is called as a hemarthrosis, is common in hemophilia A and is almost diagnostic of disorder. Recurrent bleeding into joints leads to joint destruction and joint deformities. Earlier, when HIV screening of donor blood was not widely adopted, many hemophiliacs got infected with HIV due to factor 8 transfusion, and many of these have already developed AIDS. However, this is uncommon now due to universal screening of donor blood. Investigations. Partial thromboplastin time, that is PTT, is prolonged. Platelet count and PT are normal. Bleeding time and fibrinogen levels are also normal. Factor 8 levels are reduced. Treatment. Treatment of hemophilia A involves an infusion of factor 8 concentrates, either recombinant or a heat treated. In minor bleeding, It is enough if the factor 8 levels are raised to 25% of normal. For moderate bleeding, levels should be kept above 25% of the normal. When major surgery is to be performed, factor 8 level should be raised to 100% and then maintained above 50% for 10 to 14 days. For mild hemophiliacs, DDAVP, that is desmopressin, is enough for minor surgeries. It causes release of stored factor 8 and will raise the factor 8 levels 2 to 3 folds for several hours. EACA, that is epsilon amino caproic acid, may be added if bleeding persists after treating with factor 8 and desmopressin. Fresh frozen plasma can be used if factor 7 concentrate is not available. Emicizumab is a monoclonal antibody that binds to both factor 9 and factor 10, link them into factor 10 as like active complex that obviates the need for factor 8 and may be an effective treatment for hemophilia A. A gene therapy is currently in development phase. Avoid the use of aspirin in these patients. Patients with hemophilia should be vaccinated against hepatitis B. Prognosis? Prognosis is good now because of availability of factor 8 concentrates. Intracerebral hemorrhage is the usual cause of death but uncommon.